Good afternoon, everyone. My name is Kay Johnson, and I'm the co-chair for the InCK National Advisory Team and a partner in this work. Today, we're going to have the fourth in a series of webinars hosted by InCK, this one on equity, health transformation, and early childhood systems building. We are appreciative of all of you who've signed up and been able to join us today. We're going to be taking comments and questions in the chat throughout, and we will have time where I moderate your questions later on with our panel. We appreciate you being here to be a part of this with us. The series of webinars that we've been doing began with one about the framework on child health transformation and continued with one about practice transformation. In last month, we talked about, hold on one moment. Pardon me, a lot of pollen in the air today. The third one continued around COVID transformation, including what we were hearing from key practitioners. And today, focusing more on equity. And each of them can be identified as well as working papers at incmarks.org. So today, as I said, we're going to be talking about child health transformation, equity, and systems. And Charles Bruner is going to be speaking about that on several points. And then we're going to have a panel of respondents talking about moving ahead and the challenges and opportunities of our times. So as many of you know, Charles Bruner has spent the past 40 years in child health policy and a range of other areas with a particular emphasis on public responses that succeed with children where current systems fail. Charlie brings together experiences in academic with a PhD in political science, as a politician, 12 years in the Iowa legislature, and an advocate with 25 years heading a state child advocacy organization. His experience encompasses work on issues related to child health, as you may know, but also child welfare, juvenile justice, welfare reform, early care and education, family economic security, and community building. Charlie tells us that the common theme of his work is to advocate for public policies and investments that can enable parents to be the best parents they can be. And he's the InCK network manager, the leader of this project. Maxine Hayes, the first of our panelists, is a nationally recognized maternal and child health expert and the former state health officer for the Washington State Department of Health. As the top public health officer in that state for 16 years, Dr. Hayes was charged with advising the governor, the Secretary of Health, health professionals, and local health departments, as well as the public. She has dedicated her life to teaching and public service. Dr. Hayes grew up in Jim Crow South in Mississippi and was studying in Vienna when Martin Luther King Jr. and Robert Kennedy were assassinated. She returned to the U.S. to complete her degree at Spelman, an historically Black college, and went on to earn her medical degree from the State University of New York at Buffalo and her master's degree in public health from Harvard. She's held faculty positions at the University of Washington, and today she's here in part as the co-chair of our InCK National Advisory Team with me. Dr. Fan Tate is the American Academy of Pediatrics Chief Medical Officer and Senior Vice President of Child Health and Wellness. A pediatric neurologist, Dr. Tate brings years of experience in child health and wellness, family-centered care, medical homes, children with special healthcare needs, and healthcare delivery. She's led work on many of the strategic priorities of the AAP, including Bright Futures, Early Brain and Child Development, and the National Center for Early Childhood Health and Wellness to address health and Head Start and child care. Before coming to the Academy in 2005, Dr. Tate was the Bureau Director of Utah's Children with Special Healthcare Needs program. Dr. Wendy Ellis is the Director of the Building Community Resilience Collaborative and Networks at the Milken Institute School of Public Health at the George Washington University. She has spent the last decade working to grow a resilience movement to address systematic inequalities that contribute to social and health disparities. Prior to joining George Washington University, she served as a manager of child health policy in the Moores National Office of Child Health Policy and Practice. In 2018, Dr. Ellis was selected as an Aspen Institute Ascend Fellow. She also has been a Milken Scholar at George Washington University, where she earned her DRPH in health policy. She also holds an MPH from the University of Washington School of Public Health and attended Seattle University. As you can see, they bring a wealth of experience and knowledge. After the panel responds to Charlie's comments, we're hoping to have active dialogue in the chat to have more collective advocacy for collective impact. So with that, Charlie, I turn it over to you.
Well, thank you very much, Kate. And really my role here is to set the stage for the commentary you're going to hear from our three great commentators, and really want to thank Kate for doing the moderating and a lot of the work in the development of this PowerPoint presentation, and for her leadership on the InCK advisory team. We started InCK, really the predecessor to InCK was a child health, equity, and young children initiative, and we have really focused on those issues of child health and health equity. And here's the definitions of child health that we use from the field, which really is much more than merely the absence of disease or infirmity, but it's really healthy children live in families, environments, and communities that provide them with the opportunity to reach their fullest developmental potential. And health equity is really ensuring that all kids can achieve their goals and visions, with a special emphasis for children who are either through socioeconomic disadvantage or current or historical injustices thwarted in their ability to do so. So we have really worked with InCK to focus on how can we move forward with our child health and health equity. Even before COVID began, our mission and agenda has been to support leaders in the field to advance healthcare transformation, to produce different state-of-the-field resources, including webinars like these, and really to work with our national advisory team. And on the right-hand side is our framework for child health care transformation, which is really, it's around practice transformation, but that can only be achieved if we also do that with respect to metrics transformation and finance transformation, and do that within a culture that responds more holistically and responsibly to children and families. And the next slide actually describes these practice elements. I'm not going to read them, but just that practice transformation really does emphasize partnering with families and being embedded in the communities they serve. And culture transformation really does have that strong equity perspective and the recognition that we have to be culturally and linguistically responsive to all children and families, but we also have to work to rectify inequities that do exist. The basics of our work, if we boil it down simply, is really, it is about transformation, which is more than just incremental change. It's about fundamental change in overall goals and structures. And really, in this case, as we focus on child health care, it's transforming from a medical care system that does provide for meeting medical needs and doing medical treatments to a healthcare system that's really designed to improve all domains of children's development: physical, cognitive, social, emotional, relational, and language, in a way that really partners with families and with an emphasis on equity. We have found this to be embodied, and again, there's an article that Kay and I did on Medicaid's role in financing early childhood that put forward a concept of a high-performing medical home as the form of transformation in the pediatric setting. And we built it upon a lot of exemplary programs and practice and systems change efforts. And it really restructures and enhances the office practice role and the relationship with families in a real relational approach. It incorporates a care coordination that really starts from where families and children are and helps them to build agency to realize their aspirations and goals. It's really concertedly linked to and often finances types of health-related services that will support the family and the child's healthy development, and really that valuing and partnering families and recognizing it's imperative to combat that inequities. As we've looked at our high-performing medical homes and what practices are doing or trying to do and aspiring to do within the limits of what they have in the way of resources, we've really found that practitioners do envisage, and I think Pam will talk a good deal more about this from the perspective of the AAP, really moving from medical care to broader health care, which means identifying and responding to family circumstances, not just child-specific medical needs, and working with families to advance healthy development, really through relational health and strength-based approaches that recognize the role of families and communities as being imperative, that really recognize, value, and respect culture, language, and ethnicity of the children and families they serve. Themselves are practices that are learning communities around being inclusive, diverse, and promoting equity, really with and through the involvement of the children, families, and communities they serve. And again, many of the exemplary practices we talked about in our second webinar really have shown the value and the benefit of really being learning communities and focusing on inclusion, diversity, and equity, and building medical home teams that themselves reflect the racial and ethnic composition of the communities they serve, and really reach out to and engage and support the community in its work, that provide opportunities for partnership with families, and that really advocate within their communities and their spheres of influence for equity and eliminating discriminatory practices. So when we talk about child healthcare transformation, the issues around equity and responsiveness are embedded in all of the aspects of transformation and what the practices do with themselves and with others. I want to go on a little bit more about why equity is so important for healthcare and the work that you all are doing. And this is a quote from Martin Luther King that he made: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And really the role of the healthcare system needs to be to create availability and services that support the healthy development of all children. And I picked a couple of pictures of Martin Luther King, one with his own family and one on a march with children, which really emphasize the importance of looking at that equity, but also looking at it not just from an adult perspective and where we typically look at injustice, but from a whole child perspective and growing up. It really is essential to achieving equity. And the problem, and I think we all kind of recognize and know this, that too many children don't have access to the services that will optimize their health and well-being over the lifespan. A quarter live in poverty and or communities with concentrated disadvantage. And for children of color, only a third are in families with incomes at a middle class, compared with 2/3 of white children. So the norm for the children of color really is to be in a struggling family below the kind of the middle class level of making ends meet, compared with white children, where the norm is much more in the opposite direction. And 1/3 are at risk of long-range health and developmental problems, some due to biological medical conditions that aren't well addressed, but often due to the challenges that families face, economic and social, and the communities in which they live. And certainly, as evidenced by just the poverty status. Profound inequities exist by race, place, and socioeconomic status, and children of color are more likely to be poor, on Medicaid, face environmental hazards in their neighborhoods, and have the added burden of racism. So transformation really is essential to address negative social determinants, confront racism, and rectify inequities. And when we're talking about this, we're really talking about not a small but still important number of kids, but we're really talking about at least a quarter of the child population. And this slide, and I won't go into it, but it really just trying to say that poverty and racism are intertwined, and it's important we address both, but they're not the same. And that as we work for transformed health systems, we need not only to be unbiased, but also to confront racism and work to rectify inequities, and promoting those through working to ensure that families do have economic security, but also that they are in no other way othered from society, and that they are enabled to support their children to grow and develop. So that was kind of the introduction, and I'm going to go through kind of quickly where the transformation in child health care fits across early childhood services systems building efforts, and where I think it plays an exceedingly important role, particularly from a preventive, promotive, and developmental perspective. We're going to have our next webinar on adolescence, where it plays, embraces the same principles for the child healthcare transformation I discussed, but it actually has different roles in terms of the developmental context and the role of the health practitioner. And that's a great picture of a mom and a young child, and I put in these little balloons saying that, you know, in the back of that mother's mind is, will society ensure my child is safe, lives in a healthy environment, is valued as all children should be valued, and supported and not hindered in pursuing her dreams. And that child is beginning to ask questions about how will the color of my skin affect how I am treated, how will my parents and society support and protect me as I meet others and widen my world. That it is really, while we don't think about issues of racism, marginalization, denigration occurring when we're talking about an infant, and we don't think about them as needing a civics lesson in participatory democracy and inclusion. They're learning, growing, and developing, and they are learning who they are and how they're being treated. And we have to make sure that they can really feel that the environments they're in are affirmative of them as individuals and as members of their racial, ethnic, and linguistic group, and as they grow up, and that there aren't barriers. There is a lot of work now around healthcare transformation and early childhood systems building, and a whole lot, particularly in the birth to 3 years, looking at what do we need to do to get kids off to a right start in the first 3 years of life, and cite the Early Childhood Systems Working Group, the ECCS initiatives, the Pritzker's Children initiatives, the Multi-Foundation Pediatric Supporting Parents Initiative, AAP working groups, which we'll hear about a little more from PAN, Aspen 2-Generational Model, National Academy of Sciences publications, and many others have aligned frameworks for early childhood systems, what we need in a system to support children's healthy development. And they may phrase this a little bit differently, but they've come to some common themes about what we need. And those, then they all have, we need components that respond, that provide health care, that provide early care and education and learning environments, that provide economic security and opportunity for the family, and that really do provide family engagement and empowerment. And that goal for the overall system is that there's no wrong door wherever a family may walk in, but there always is a door. And that when a family comes in, there are seamless integrated responses. And those are ones where the child and family really are at the center and are recognized as the agent that we want to respond to. And they are the customer, but they're also the contributor to their growth and society's growth. And there's an emphasis upon equity. And the next slide really says all of these systems are aligned in what they want to do. They want to provide high quality services. They really, when kids are very young, want to strengthen safety, stability, nurturing, and relational health in the home and community. They also want to contribute to optimal child development, which they define as physical, cognitive, social, emotional relationship, and language. They all want to advance equity and reduce disparities, and they all want to engage families in a respectful manner in authentic partnerships. And when we look at those systems, all are recognizing, I think, in some measure, that to be able to do that and do that well, they are also needing to undergo transformation. As indicated before, really for health, it's from a medical care system to a child health care system. For that early care and education world, this is really from a child care system of providing some affordable and available child care for people who work, to an early learning environment that wherever a child is, that child is loved and guided and supported and nurtured and provided the developmental supports they need. In terms of economic support, this really moves from a basic needs maintenance system, which we do provide needs-based aid to produce some predictability of resources for very basic living needs, but we don't really provide something that allows families who are struggling economically to invest in their kids, to really move to an economic security and opportunity system, providing sufficient support to raise and invest in their children and to advance in earnings and career. And for the family engagement empowerment piece, this really involves using a strength-based, family-driven approach in health, in early learning, and in economic security and opportunity, and really sharing power, and really in contributing to community building, particularly through supporting community institutions and families within communities in providing resources, opportunity, and times, places, and opportunities for their kids to grow and develop. If we look at the status of the early childhood system today, I think the reality is that each of these systems has not been developed to really fulfill the missions that were set out in that framework on the last couple of slides. We have gotten to the point in medical care that 96% of kids have health care coverage, 91% of young children do have well child visits, most with a stable source of support, but a tiny fraction of those really have high-performing medical homes, and most practitioners feel they have very limited capacity to make effective referrals to other services or really step too far outside the medical field of practice to achieve success. In early care and education, we have very much too little affordable quality child care and a huge gap between what parents can pay and what it takes to provide that care. In family support, we have only small and limited efforts really that do engage and strengthen families, like home visiting, early Head Start, family development services, probably at most reach 1 to 5% of the population in any state. And we have mostly income maintenance and subsistence programs that don't provide much of a margin of error way to invest in future opportunity. And we certainly want to see all of these systems grow and develop. The more they can fulfill their missions, the more they're in place really to provide much more integrated services and aligned services with one another. Many of you have probably been involved with different efforts to do early childhood planning at a community or state level and bringing together these forces. And when they do, often the efforts are primarily to develop integrated services, generally do seek to provide more relational family support, and do see that what we really have to do is we have to make sure that we respond to where families are, and we build upon their strengths, and we recognize their critical roles as the child's first nurturer, caregiver, teacher, and nurse, and support them accordingly. I think I have one more slide on kind of the framework, but this means that for us, as we look at our work, we're looking at what within the practice, the health practice can do to really move from being a medical care provider to a healthcare provider, which really means moving to be health practices becoming high-performing medical homes, which provide that relational care coordination and coverage of a variety of dyadic services that really do put the family at the center, but also that refer to other sources of support for the families, and that as a partner with other practices, they really do collaborate and offer the types of medical expertise they have so that other families can work well with children and families, and where possible, really contribute to overall systems building. The particular role for health in very early childhood, 0 to 2, is just, I think, really critical, even more so than in 3 to 5, where it's still important, because this is the time when kids are learning through those most intimate serve and return activities in their circle of security with their family. And this is the time when they see the child health practitioner most often, and where the child health practitioner is likely to be the sole source of professional outside contact, who can begin to be that first responder and contributor to that child's growth and development, and really the responder to the family's needs. And they remain important in the 3 to 5 year old years, and still they have that continuous contact, but the role does shift. So I've tried to present the background and what we've been doing and how we fit child healthcare transformation within early childhood systems building, and also put it as part of our overall emphasis upon achieving better results for kids and rectifying inequities and responding. And I think we've all felt a new urgency because of COVID, its differential impact upon kids of color, because of the racial violence that has existed in the last given call, and I think rise for real reforms in a way that we certainly hope is enduring. And we recognize that we've had a lot of disruptions. Primary child health care won't come back the way it was. Child care won't come back the way it was. But there is an increased recognition of the role that child care and primary care needs to play, and the role of helpers in society that can provide an impetus for taking action and building upon urgency to do a much better job to advance child healthcare transformation in the context of early childhood systems transformation. So here are just a few.
Charlie, about one minute.
Yeah, 1 minute. Yeah, and here are just three causes. Never let a good crisis go to waste. Transformation involves being in the right place at the right time with the right capacity, and we can't go back to the old normal. We must build back to a better normal. I think are where we are right now at a crossroads. And that really is my segue into the commentary we're going to hear. I've said before, it really is about physician transform thyself, but systems and policy need to provide the supports for that transformation. And undermining it is about achieving equity and dismantling racism, with healthcare playing that important role. So this question was the one that we posed to as a starting point for their commentary. What do we need to do to build back a better, smarter, and fairer child health system? And now I am going to turn it over to our first commentary, Maxine Hayes.
Thank you so much, Charlie. And these are unprecedented times, but I think this also at a time that we can say we have unprecedented opportunities to do much better than we're doing. Let me introduce you to the accountability that I put and keep in front of me, and that is my 6-year-old grandchild, who is a member of the class of 2020 kindergartners. She says with one of her signs, the future is watching. The future is watching. And today, I think we're at a crossroads where we can choose to make things right. I have always believed firmly that the foundation for a healthy society is built in early childhood. And that if we can get things right in the beginning, then we get them right over the life course. We have seen so many systems failures in the crisis that we have in front of us related to the pandemic. But we also have another crisis, and that crisis is one of massive injustice in the policing in this country that disproportionately impacts African-American males. Having raised 2 African-American sons, I can tell you that there are so many discrepancies and so much discrimination and so much prejudging that I can only hear the cry of the 12-year-old that says, I just want to live. I don't know how many Americans can live with that sound, that voice. We need to listen to our children. And they're watching us. They're watching us. Racism is in all of our systems. And early childhood systems is not an exception. We have to be willing to look internally to all of our systems and ask the question, how is racism operating in this system? And be willing to change it. We have to honor our families, listen to our children, because we can take the experiences that we have now and build a better future. I marched with the civil rights movement when I was an adolescent in Mississippi. And my son and his daughter are marching today because of injustice in policing. I hope that my grandchild won't have to be marching to get and to have a future that every child should have, and that is to live out their full potential in a society that values them. The economic crisis we're seeing already, 25% of our kids are already, as Charlie pointed out, in the group that have disproportionate burden of just basics. But the coming epidemic will be that of mental illness. And we know that we are now seeing an uptick in the number of suicides among African American youth. Health equity, I'm glad that we pulled out, but it will not be achieved until we address the number one determinant of health, and that is racism. We've got to do it. The future is watching. I'm going to pass it on now.
Thank you so much, Maxine. We so appreciate hearing your perspectives. Anne, we turn it to you.
Okay, thank you. Good afternoon, everyone. I feel like I could just say what Maxine said. And also what Charlie said. I want you to know what a privilege it is for me to even be on this panel with Charlie and Maxine and Wendy. I look at the question that says, build back a better, smarter, and fairer system. And I say, as Maxine alluded and Charlie has, it's building. It's not even building back. We haven't gotten to where we should be yet with the correct health system. And I so agree that this is about health. This is what we're looking at and what we need to look at. In the next just few minutes, I was asked to just comment on what we're doing, what we're thinking at the American Academy of Pediatrics. And I will tell you before I jump into this that, as you all know, this is a journey. As Maxine said, I look at what we're talking about today as you can look at it however you want to. I think there are two pandemics. One is racism, and you all have heard others say this, but one is racism and one is COVID. It's that one's been around for 400 years, and I agree totally with Maxine that we have to change. So next slide, please. So let me run through these. So American Academy of Pediatrics, 67,000 pediatricians and colleagues. And we have articulated an approach to equity. This was one from a few years ago where we talked about an ideal that all children and all systems maintain health equity. And what we have to do is equip pediatricians to create equitable systems and look at the optimal health for all children, I would underline that. And we cannot do that as just a group of pediatricians, as you all know. Next, please. So one of the things that we've been looking at over the last 4 years, we started out with a task force with wonderful leaders, pediatricians and colleagues, other colleagues. And we looked at the task force, had a task force on diversity and inclusion that particularly addressed some of the issues as child health professionals and organizational, whether that's things like the pipeline or leadership within the academy and otherwise. And then we just finished a year and a half ago with a task force on addressing bias and discrimination. And you can see that there's significant overlap, but the overlap has to do with what we're all talking about today, which is child health equity. So whether we're talking societal or children and families or professionals or organizational, that's what we're looking at. Next slide. So I pulled out two things. You should know that with diversity and inclusion and bias and discrimination, you can imagine that we have anywhere from 20 to 40 specific recommendations, which I did not want to, I thought I would just go high today and a higher level to say, one of the things that the D&I group said, and you all know so well, is that the commitment has to permeate all aspects of an organizational and its functioning, and it must be collaborative, explicit, and nationally visible. And let me tell you, I want you to know that we're working on all of those. We're not where we need to be on this. Please don't think that I or the AP think that we are where but we're trying. Next. So this one was from the Bias and Discrimination Task Force. Said, well, of course, you can't address bias and discrimination if you're not looking at D&I and vice versa. So here's what we're looking at across the different competencies: education, policy, advocacy, research, and clinical practice. Next, please. So I won't go through all of this, but what you can see in the squares is that we are looking at ourselves with respect to our board and our staff, and looking at D&I in that area with our committees, councils, sections, chapters. We're looking at policy and practice. We're looking at how we collaborate with all of you as partners, and also what do we provide our members. And then just the last couple of slides, I will just give you some examples. So I hope that you all know about this and have read it. Dr. Joe Wright was on a call with us the other night, and he said, we just need to implement this policy statement. Implement, right? It is not that you just, a policy statement from our perspective is that's great. It's one of the most important things, and it's used not just by pediatricians, but by different groups, thankfully, across the United States and some places in the world. But it is a policy statement. Next slide. So we have a lot of policy statements, right? So we have the one on poverty. We have the one on immigrant health, homelessness, social determinants of health. And you will remember back a while, and we're just redoing our early childhood adversity. Should be coming out again soon. Next slide, please. So one of the particular areas that it's been our privilege to work on over the years is Bright Futures, right? So Bright Futures, I hope you all know that Bright Futures is what we talk about with well child preventive care, from prenatal through young adulthood. I put this in as an example of what we have to do, not just say, but do. So the priorities for the 6-month visit: first priority is what concerns the parents. Second one you will look at is some of the social determinants of health, and looking at strengths and protective factors, not in a negative way, but where's the part right now on questions about racism, and how are we moving in that direction? So we are taking a look at those issues, obviously, too. In the last slide. So I'll be turning this over to Wendy. One of the things that I wanted to say is if we're educating our members, we're looking at the clinical piece of that, the community piece of that, the advocacy piece of that, and also at the structural piece of it. And Wendy, Dr. Ellis will be talking some about structural racism, and we're looking at that piece of it too. Thank you so much. Wendy?
Thank you.
Well, thank you, Fan, and it is quite the honor to follow both you and Maxine to provide commentary as we begin to think about what child health system transformation looks like. And my remarks are really going to challenge you to think about that process of transformation that really begins with truth. It's a truth that will lead us to a reconciliation, but also forces us to begin to look internally before we can begin to have a practice change in understanding even how we view the adversities that are facing our children and our families. Go to the next slide, please. So many of you may be familiar with our Pair of Aces tree, that we were quite intentional in starting our work with 5 child health systems almost 5 years ago. to really think about not only the adversities that oftentimes we see in pediatric practice, but to force ourselves to think about the adverse community environment in which they occur. So when you think about the social determinants, which many of you see there as the root causes there in this tree, really we want to challenge the thinking that there really is nothing social about these determinants. That these things that we see with regard to the effects of poverty, racial discrimination, the lack of opportunity and access to economic mobility are not necessarily just choices that individuals make, but they're choices that are available within constraints of structural racism. That the outcomes that we see related to these so-called social determinants are really baked into the systems. They are quite intentional. So helping our physicians, our other service providers understand that if we merely focus on the leaves and the branches of that tree, we're really only treating the outcomes of these systemic drivers. And so that forces you from a practice physician to really think about the context in which your care is being delivered. Truly, if we are thinking about and focused on transforming outcomes for individuals, then we also need to be focused on these system drivers that are doing exactly what they were designed to do. So if we can go to the next slide. The reason why I put in here why they are designed to do exactly what they were intended to do is this very hard truth, which is the first step in us understanding how we get to transformation, how we come to a better normal. And that's understanding this very hard truth that much of this country, in fact, all of our public systems, are influenced by a belief in white supremacy. And I want to separate the white supremacy as a quality of individual versus what is a principle that has informed all of the policies and systems. So this belief that white people should dominate all other races is built into every one of our systems, every one of our policies, going back 500 years, not just 400 years. But from what happened to the indigenous people, to the Africans who were brought over here, to what's happening today with our crackdown on immigration. It has always been to create these systems and policies that are designed to empower a white supremacist belief. Therefore, when we look at these disparities and white people are always at the top, it is by intent to have white supremacy as the outcome. They dominate in power, health, well-being, and wealth, and in a very brutal manner, as was displayed last week with regard to, within the last few weeks with regard to the death of George Floyd, the harassment of individuals by having police called on them indiscriminately, knowing that you can access levers to power that have very brutal consequences for individuals of color in this country. That is our brutal truth that we must reconcile, and that is the context in which any child health transformation is occurring. So when we talk about the pandemic, within the pandemic, COVID will eventually pass, but this is the pandemic of which we must solve. And so when we talk about child health transformation within the work that I do with the Center for Community Resilience, it is helping our physicians and service providers understand that connecting across these sectors, that serving as an influence across these sectors to really build equity, to dismantle systematically these levers, the policy levers, the practice levers that actually help us to break down this cycle of white supremacy. They're difficult conversations, for sure, very difficult conversations. And we actually have created a tool that's on our website, the Fostering Equity Tool Guide, that helps to foster these conversations, creating the safe space. This isn't just led by PhDs, this is led by individuals and communities, building across these sectors, using those things that really help us to understand each other's lived experiences, not just looking at our systems data, our utilization data, but really understanding the lived experience. So when you begin to think about what does practice change look like that is going to be most effective, it's recognizing that the effects of poverty are having a disproportionate impact on our patients and our families of color, that racism itself is a trauma. Just that mere understanding really does change. What do we do with screening? What do we do with practice? Getting to the heart of what is really driving the outcomes that we see. So I'll do my final slide here because it was really important. If you can go ahead and change slides. When we talk about this pandemic within a pandemic, we took the Parabases tree and actually changed it for the COVID-19 because what we were seeing really disproportionately, that COVID-19 was laying bare all of the underlying inequities that we had seen. So the root drivers, the systems drivers did not change. What's in the soil of our communities did not change, but the outcomes became even more pronounced. Thinking about housing instability, food insecurity. Here in Washington, D.C., Martha's Table has been in a part of the community for years as far as addressing food insecurity and lack of access to childcare and such. And just since March 13th, that one outlet alone has been distributing more than 800 bags of groceries a week because of the increased demand. It really does help us to understand not only the disproportionality in who is affected, but how fragile all of our systems are, and intentionally so. And so when we begin to think about what does an equitable system look like, it's not just equitable access to health care, particularly if we're throwing people right back into these same environments. It is looking at how can we, as healthcare systems and providers, actually influence other systems, work with our community to advocate for systems change, not just health systems change, but systems change writ large. So the challenge to us when we talk about building a new normal is not just transforming child health systems, but how will we build equity writ large? Thank you.
Thank you, Wendy. We really appreciate all of the panelists and Charlie's presentation for today. We don't have a lot of time. I know that people are asking just to reaffirm all of the slides, and a recording of this will be available through the InCK's website. I know Wendy's materials are on her website, and that was showing, and certainly the AAP statements are widely available, and we can include links to those. So we did not have a lot of questions come in, and since we have a short amount of time, I'm going to put the second question to our panelists, and it's sort of, it's your wish, it's your big ask, it's your big bet. Where do we need to make investments that would improve young children's health and development? And clearly, each of you has made a large call to action. But if we could ask you to focus in on one thing, I don't know if it's where do we go first, where do we put the most money? I know you've all been thinking about that, and we're going to go in reverse order with Wendy going first.
Great. I think that, all of us know that what is the greatest insurance for children is to make sure that they have at least one stable adult that can support them. And so when we think about these 2-gen supports for families, I think it is very important that, yes, we have a larger investment in early childhood education, but we also have to think holistically. Are we setting parents up to succeed? Meaning, housing stability, guaranteed income, the supports that parents need so that their children so that they can be there to support their children. And yes, that does include the quality of child care services. I see, Christopher, you had a comment there. So yes, it includes that as well.
Thank you. Fan?
Yeah, thank you. So I have a big list of wishes. I'll cue off a little bit of what Wendy just said. I think that my big wish and big bet is that that particularly coming into this election, that every time there was any question or discussion about policies going forward, the question was, how are the children and how are the families? We don't hear it, right? We don't hear that question. Now, it's not for lack of us trying, Charlie, and all of us, but I think that practice transformation is a critical piece of this, but I think all of us, in order to make this difference, we have to have a long-term, explicit commitment to change with specific strategies, and we are all accountable for making this happen. So my wish is that this is not a moment in time, but a transformational moment, finally, as we move forward. Thank you.
Thank you. Maxine?
And my wish is that we would have solidarity around the message that we want policymakers at all levels to hear and see. There has never been a time quite like this where people are beginning to connect the dots, but some of them need help in connecting the dots. What we're talking about in terms of investment in young children, this is over the course of their life, and it impacts their health even as adults. So when we see the outcomes that Wendy so beautifully talked about, we're also looking at what we didn't do earlier. So that's the one wish that I would have, is that we now connect the dots and then act on those dots that have been connected.
Charlie, in 1 minute.
I'll do my best. Here's a quote from Bruce Leslie at First Focus around making child policy a real priority, and the fact that we've had a history of selling ourselves short and being too nice. I think in the early childhood space, we have to recognize that we are not making the investments we know would make a difference in health, in early care and education, in family support, and in family economic security and success. And one of the good things about COVID-19 and its response is people are talking in terms of trillions or hundreds of billions of dollars, that we have to ask for what we need to get kids off to a good start. And that right now, the federal budget, 10% of the funding goes to kids only, and only 2% goes to young children. And if we're going to really transform those systems, we're going to need that $50 billion for early care and education the child advocates are speaking to, and we're going to need another $50 billion in terms of economic, health care, and I think most importantly, the supports that really go to addressing family needs, whether they're family support, family relational workforce, early Head Start, home visiting, or the like. We really need to make those investments, and they need to be embedded in the neighborhoods and communities and support the people in those neighborhoods and communities as their leaders. And so I hope that the transformation will include something that really does say we can't afford not to make these investments now, or we'll be looking at a future that does not address this crisis that our children face.
Thank you so much. Thanks to all of you. That we really appreciate the many guests we've had on this webinar today. Looking at the list, I know there are between 15 and 20 of you who've spent decades working on these issues as well, and we appreciate having you be here with us and learning and sharing with us today. We're adjourned. Thanks.
Thank you.